Hello. Today we'll be dealing about one important aspect of diagnosis, often which is called as final diagnosis of any disease, which is nothing but our histological diagnosis. Today we'll be talking about how do we do that histological diagnosis? How do we actually take a specimen for histological diagnosis in a surgical perspective? So our topic for discussion today would be biopsy and cytology. As we all know, biopsy is actually a Greek word which means bios and opsis. Bios means is life, opsis is vision. So in the biopsy, what happens is it is like we are visualizing, we're actually seeing what that particular specimen of a tissue or any cell contains is called as biopsy. This biopsy in a layman term is nothing but a removal of a small piece of tissue, living tissue, for microscopic examination. This microscopic examination would give us insight into how do we analyze that particular disease and the particular contents of the histological specimen and come to a proper diagnosis. This is about biopsy, what actually a biopsy is. Normally, biopsy is indicated in cases of any lesions which are present for about 2 weeks period of time, which is, a long-term lesion which is not healing even after proper treatment is given to it. Normally, most of us would think that biopsy is done to diagnose a tumor. No, biopsy is done to diagnose any unusually looking diseases. For example, we could not diagnose, come to a final diagnosis by proper clinical examination or by radiological investigations or serological or hematological investigations. In those cases, what happens is we go into a histopathological diagnosis for having a clear-cut, evidence of what that particular disease could be. And in case of persistent hyperkeratotic lesions and tumefactive lesions are nothing but tumor type, which are growing, like malignancies or benign lesions, anything like neoplasms, and any bone lesions such as any tumors or cysts, which are not specifically identified either by your clinical or radiological examination, and lesions which are having malignant features, like they are rapidly growing, they are indurated, and lesion is is looking like an ulcer proliferative growth. In those conditions, we go ahead with this biopsy, which will help us in understanding what the nature of the disease is and also coming to a proper diagnosis. And we have certain contraindications for these biopsies also. And these contraindications can be broadly classified as relative contraindications and absolute contraindications. Relative contraindication is nothing but, why do we call it relative? Relative is because for that moment of time, it is a contraindication. But if we take proper precautions, we can actually perform a biopsy in those conditions. So those conditions include, for example, relative contraindications are in medically compromised patients who are having bleeding disorders, or who are having, patient is having, uncontrolled diabetes, or patient is on ecosprin or, anticoagulant therapy. In those cases, why do we actually call it a relative contraindication? If patient is on, warfarin, etc., any anticoagulant, in those cases what happens is when we actually take a biopsy, there could be uncontrolled bleeding. So in those cases, we either go ahead with local styptic measurements or ask the patient to actually stop the drug for or switch the drug to another drug, like such as heparin, etc., and we actually perform a biopsy in those cases. So these are relative contraindications. There is nothing that we should not perform a biopsy in those cases. It is only thing that proper precautions has to be taken before going into performing a biopsy in those conditions. Other relative contraindications include normal anatomical or racial variations. Okay, sometimes these are actually, they might look like a disease or pathological condition, but in fact they are actually a variation to a normal thing. For example, we have Fordyce granules on the buccal mucosa. These Fordyce granules are actually normal variation. They are ectopic sebaceous glands. If we don't know that they are ectopic sebaceous glands and we are going ahead in performing biopsy, it will be futile because it is actually a normal variation. So in such cases, what we do, we actually contraindicate, relative contraindication of a biopsy. However, if you suspect, though the normal variation is present, for example, a nevus is present, in those nevus conditions, what happens? It is a nevus, normal nevus. But if we suspect that it could be a melanoma or it could be a malignant, turning pigmented lesion, then we can go ahead with biopsy. But in those cases, remember, always perform excisional biopsy in all pigmented lesions. Never go ahead with incisional biopsy because there could be a risk of sample bias or sampling error. What happens is when we are actually taking an incisional biopsy in those cases, or small piece from the whole lesion, then we might miss, the lesion's aggressiveness or lesion's, invasiveness of into the underlying structures, for example, invasiveness of melanoma. So in those cases, always go ahead with the excisional biopsy in pigmented lesions. And in related contraindication is if it is proximal to any vital anatomical structures. So in those cases also we will go ahead with different procedure or different technique in taking biopsy to prevent any injury to the adjacent vital anatomical structures. So these are the relative contraindications, and absolute contraindications are any pulsatile vascular lesions, for example hemangioma or arteriovenous malformations. In those cases, do not perform biopsy unless you take an aspiration. If the aspiration reveals frank blood and if the clinical symptoms or clinical features are very much near to your hemangioma or any other vascular lesion, pulsatile vascular lesion, do not perform biopsy because bleeding could not be so well controlled in those cases. And in case of intrabony radiolucent lesions, in this intrabony radiolucent lesions also most probably there could be a vascular lesion, and hence in those cases also always precede the biopsy with a aspiration biopsy or aspiration technique, so that this will give us an insight whether to perform a biopsy in that condition or not. And pigmented lesions, as I have said, should not be biopsied incisionally. They have to be taken completely, that have to be excised and then sent for histopathological diagnosis. So these are about relative and absolute contraindications of our biopsies. Now coming to types of biopsies. Now types of biopsies can be grossly or majorly can be divided into excisional biopsy and incisional biopsy. Excisional biopsy is nothing but, as the name itself indicates, it is completely, we remove the whole tissue and then send the whole pathological tissue which we suspect to the histopathological diagnosis. Normally these excisional biopsies are done in case of benign lesion, in case of proliferative lesions which are pedunculated, in lesions which are less than 2 centimeters in size, and in lesions particularly which can be removed without mutilating the patient, without causing much damage to the patient. In those cases we go ahead with this excisional biopsy. Incisional biopsy is usually done in cases of a large lesion where it is more than 2 centimeters in size, in cases where the site is inaccessible. For example, this tumor or tumefactive growth is present deep into the soft palate, or it is present at the base of the tongue, or it is present on the ventral surface and extending on into the ventral surface of the tongue, extending into the floor of the mouth. In those cases what happens is we could not completely excise the lesion and send it for histopathological diagnosis because of various complications within a dental office. So in those cases what we do, we remove a part of the tissue from the pathology and then send it for your histopathological diagnosis. This is nothing but incisional biopsy. And in this excisional and incisional biopsy, we have again various variants and how do we actually perform the techniques in this incisional and excisional biopsy that we will be seeing in our next slides. Now coming to this excisional biopsy, as I told you, it is excision of the whole lesion, and in these cases what we do is we also excise the perimeter of the lesion. Now for example, this is the lesion, we excise the surrounding normal tissue also to make sure that the lesion would not recur. Okay, so to prevent that recurrence we go ahead with this excisional biopsy with the negative margin around it. Okay, then indications, as I told you, these are small lesions, pedunculated, tumefactive lesions, etc. can be done with your excisional biopsy. Now coming to incisional biopsy, this incisional biopsy, as I already told you, only samples of representative part of the lesion are taken here, and indications are if you suspect any malignancy there and hazardous location, for example it is very near to an important anatomical structure. So in those cases what we do is we actually do an incisional biopsy rather than excising the whole lesion. And in case of large lesion, because it can result in a mutilation or it can result in a large surgical defect which might be further may lead to, if it is in the bone, can lead to pathological fracture, or it can lead to an aesthetic complication, or it can actually mutilate the patient's appearance also. So in those cases we first perform an incisional biopsy, and if we think it is a benign lesion then we'll go ahead for the treatment that is according to your benign lesion. If it is a malignancy then we go ahead the treatment that is in access to your malignant treatment. Then coming to principles of biopsy. Yes, principles of biopsy, always remember, take a biopsy from the most representative site. Okay, if we have a lesion somewhere and then most of the clinical features are present in that particular site, take a biopsy from that lesion. That is the most representative area. Always when you're taking a biopsy, it is always better to go into a deeper and narrower biopsy section. For example, we have a lesion here like this. So take a deeper section and a narrower section. Do not scrape a shallow section. No need of a broad and shallow section. It is always better to have a narrow one and a deep section. So how can we achieve this? By going ahead using a wedge fashion of taking a biopsy. Wedge fashion of biopsy is nothing but we cut in a V shape, two V-shaped lesions. So ends will be like this, and in this V-shaped lesion when we are cutting, we actually take a wedge of the tissue there. Usually a biopsy is done in a wedge shaped fashion there. An area that shows complete tissue changes have to be taken, and always avoid necrotic tissue. So how do we know the tissue is necrotic? Always there is on a simple logic, no? The center of the lesion is usually necrotic, right? So in that necrotic tissue, you have to avoid that necrotic tissue there. So avoid necrotic tissue. Do not take a tissue specimen from the center of the lesion if you are doing an incisional biopsy. Always take a biopsy specimen from the edge of the lesion and also include adjacent normal tissue. Why include an adjacent normal tissue? When we have an adjacent normal tissue, we can actually compare with the normal tissue. The pathological tissue can be compared with the normal tissue. So biopsy from the edge of the lesion to include normal tissue has to be taken care. And then coming to various techniques, biopsy techniques, we have various techniques, and I would list out them. The first one is exploratory biopsy. Exploratory biopsy is usually done in case of any internal lesions. For example, within the viscera or within the intraosseous lesions, what we do, we have this exploratory biopsy condition. In this, how do we do the exploratory biopsy? All the exposed tissue is removed and we go deep into the area, wherever the lesion is situated, and then we bring out a tissue specimen from that. That is nothing but exploratory. Next is punch biopsy. Punch biopsy is usually done with the help of a specific instrument called as punch. It is usually available in a pen-shaped lesion, pen-shaped design, instrument kind of thing. We have it in steel and also in a plastic disposable variants. And this punch biopsy will actually have a small cutting edge which will be of various diameters. We actually have them in 3 cm diameter, 3 mm diameter, 6 mm diameter, 1 cm diameter. Like this, we have various mm's of diameters. And in this punch biopsy, what we do is, for example, this is a tissue that has to be biopsied, and we take this, for example, this is the punch. We take this punch and pierce into this lesion, rotate it nicely, because the edge here which we have with the punch is usually sharp, okay? And when we actually do it like this, nicely turn it and then pull it back, you have a nice lesion there. Now with the help of some tissue forceps, you drag it and nicely give a small incision on the edges that have been still tagged to the surface of the lesion. So that is how punch biopsy can be done. Punch biopsy is very much useful, for removing entire depth of the lesion. Sometimes you can actually nicely go deep into the area and we can remove the tissue. And it is usually difficult where whenever we have bone very close or very in proximity to the lesion. If the bone is proximity to the lesion, then it is little difficult to perform this punch biopsy. However, whenever it is done, if proper care has been taken, we can actually go deep into the the lesion, and the whole lesion from the bottom can be removed. Normally this punch is, as I told you, will have a circular blade like thing, or treffin. It is called treffin to make a window, okay? And it is attached to a star and it is rotated with a downward pressure and then it is pulled back, okay? This is about punch biopsy. And punch biopsy can be done in cases of like where we're doing large amount of screening and we suspect a case, and instead of going ahead with all the wedge shape incisions and all that stuff, we can nicely do this punch biopsy. Less time taking, cost effective, and also will not have much of the mess. And in punch biopsy, another important thing is we need not suture the lesion, unless if it is having much amount of bleeding, or unless it is a wide lesion. Punch biopsy will not require much of suturing most of the cases. And next is curettage biopsy. Curettage biopsy is usually done in case of intraosseous lesions and also in case of friable cellular lesions. And this curettage biopsy, what we do is only small amount of surface lesion. For example, we have a lesion here. In this curettage biopsy, what we do is we actually scrape, curette, or we actually the surface of the lesion is usually scraped off in this kind of curettage biopsy. And usually this is done in case of squamous cell carcinomas, basal cell carcinoma, actinic keratosis. Actinic keratosis is one condition where we usually go ahead with this curettage biopsy. And next one is needle biopsy. Needle biopsy is another most commonly encountered one, where we have fine needle aspiration biopsy and we have core needle aspiration biopsy. And this fine needle aspiration biopsy is nothing but where we actually use a small thin gauge needle, and usually done in case of cystic lesions. Okay, we can actually insert the needle, bring back the fluid. We can aspirate the fluid and check for the fluid. For example, in KOT, that is keratogenic keratocystic odontogenic tumors, what we have is seen that creamy white color, keratin filled fluid can be seen, which is actually a characteristic feature of keratocyst. And in case of solid tumors, we usually does not get anything on aspiration. However, we get small amount of cells which can be put on the slide, and those cells can be checked for those cells can be read, or cytology can be performed on those cells, and serosanguinous fluid can be obtained. In case of hemangiomas or AV malformations, aspiration site biopsy usually gives us a fresh blood color fluid can be seen in these cases of fine needle aspiration biopsy. Now coming to core needle aspiration biopsy, also called as true cut biopsy. And this true cut biopsy or core needle aspiration biopsy, the width or the gauge of the needle is usually little larger in size. And this core usually will have a cutting edge, and inside within the core we again have another pumping kind of needle. This is usually used in case of internal organs, or in case of breast biopsies, in case of intraosseous biopsies. This true cut biopsy can be taken care. In this true cut biopsy, what happens is we actually push this biopsy needle into the bone structure or into the soft tissue mass with a opened structure, right? With a closed structure. Once we inject into it, we slowly drag the needle there. When we drag the needle, what happens is the one that is being entrapped within it is present within the needle, and we slowly bring out the needle outside again. So in this we get the small pieces of tissue which is actually enough for for the histopathological examination. So this is about needle biopsy. And then coming to imprint biopsy. Imprint biopsy is a technique where we have the tissue specimen is taken and it is cut into two pieces, into two halves. The half which is being cut is rubbed onto the slide, and that rubbed part is actually seen for exfoliative cells. But this imprint cytology is very useful, especially in cases of rapid diagnosis. We can get the report within 1 hour in case of this imprint biopsy. Imprint biopsy can also be used in case of salivary diagnostics also in recent times. Next is shave biopsy. Shave biopsy, as the name itself indicates, we are actually superficially scraping off the tissue. Most commonly used in case of pedunculated lesions, in case of any tumefactive lesions, where sharp removal of your epidermal and dermal junction by horizontal slicing is done in case of this shave biopsy. And in cases of seborrheic keratosis, in case of fibrous papules, shave biopsy is used. And wedge biopsy, as I already told you, V-shaped lesion is made, and with this V-shaped lesion we actually hold with tissue forceps, and we can cut the tissue and use it for as a biopsy specimen. In case of wedge biopsy, to stabilize the tissue, we can nicely suture the tissue and drag it. With the threads you can actually stabilize the tissue, and then we can go ahead with this wedge biopsy. Next is electrosurgery biopsy. In electrosurgery biopsy, we use an electrocautery there, and where cutting and coagulation of the tissue happens at the side by side with a high frequency and low voltage electric currents. In this high frequency and low voltage electric currents are used. Here also, one negative thing about this is usually the tissue is charred in case of this electrosurgery biopsy, which might give us an artifact while doing this in studying the histopathological specimen. Normally, electrosurgery biopsy usually will have a stalk with a loop electrode which is present, and this loop electrode is usually present engaged on a tumefactive lesion. For example, we have a fibroma or papilloma. Onto this we engage the loop electrode and we nicely cauterize it, so it will remove the tissue. And in this, one good thing is usually bleeding is not encountered because we are cauterizing the blood vessels there. Next is core biopsy. Core biopsy is again similar to our core needle biopsy. Here also we use a true cut system where we can actually take similar to FNAC, but we use a large bore needle in case of this core biopsy. Next is cone biopsy. Cone biopsy is, the name itself indicates that the biopsy is done, or the surgery is performed in a form of a cone. So we have the conical lesion is formed in case of this cone biopsy. Endoscopic biopsy, again the name itself indicates, we actually use an endoscopic probe and perform a biopsy. I mean, we will not open the site. We can usually used in case of deep lesions, in case of your GI system, in the gastroesophageal gastric region, and also on the esophageal region. We actually use this endoscopic biopsy. Next, we have various armamentarium for biopsy. As we all know, for intraoral lesion or in the head and neck region, we actually go ahead with a mouth mirror probe, antiseptic agents. We use a local anesthetic agent to actually numb the region so that patient will not have any pain. And BP plate number 15 is usually used in case of intraoral biopsies, and other units like surgical scissors, tissue forceps, needle holder, suture material, etc. will be used. And once the tissue is removed, we actually put the tissue in a 10% neutral formalin. Sterile saline irrigation has to be done in the area. Strict asepsis has to be maintained when we are taking a biopsy, and all this biopsy acquisition thing has to be entered in the biopsy data sheet, also called as acquisition forms, where patient's demographic details will be present, and also the site of little amount of the clinical findings have to be written. Site of excision is also very important, and then the requesting doctor and requesting department are usually present in those requisition forms. And this is very much important with a particular biopsy number as an OP number for the patient, so is a biopsy number for the specimen has to be allotted. So after the armamentarium, the proper site selection of the biopsy specimen is also very important. So for site selection, always determine the size of the lesion and also the location of the lesion. Based on that, we can think about whether we have to go for an excisional biopsy or for an incisional biopsy. As I already have discussed, if the lesion is small and it is will not cause mutilation for the patient and all that stuff, we can go for excisional biopsy. But if the lesion is large, pretty large enough, then we'll go for incisional biopsy. And always go ahead with the sterile technique. Remember, because if we do not take a proper sterilized technique or sterilized environment, then in those cases we might induce infection in that particular region. And when we are taking a biopsy, after the site selection, we actually have to anesthetize the patient. When we are anesthetizing the patient, usually under LA we do it. Do not paint the lesion with any antiseptic or iodine. Just you actually clean it, and adjacent area has to be clean, and do not paint the lesion completely with any antiseptic or iodine. When we are giving the anesthesia or infiltration, if you are performing a block, it is always good. But when you are going ahead with infiltration technique, in those techniques, do not infiltrate the lesion directly. Go ahead by infiltrating at least 1 centimeter away from the lesion, so that this will not hamper the biopsy specimen and hence will not give us an artifact when we are doing when we are going ahead for histopathological reading. And then avoid sections from the center. As I told you, avoid any necrotic material. Always include adjacent normal tissue. The biopsy data or the requisition form has to be filled with patient's demographic details, location of the specimen, date and history, why the patient has been any relative history that has to be, relevant history has to be mentioned within that. And then when you're going ahead with the surgical procedure, after selecting the biopsy site, anesthetization has been done, and then stabilize the tissue. While stabilizing the tissue, either you can hold the tissue with the tissue forceps, otherwise you can go ahead with the traction suture. As I already told you, suture it, do a traction, there is nothing but traction suture. This will help us in stabilizing the tissue and also gives us to how much depth we are going in. So when we are going ahead with this traction, we will know that the tissue depth is sufficient or not. Then give a V-shaped incision, that is a wedge-shaped incision, and then do the biopsy procedure. So this is a picture which is showing a wedge-shaped incision that is being taken. Make always, when we suspect any important anatomical structures that are present near to it, always make parallel incisions, that is with the normal course, parallel to the normal course of your arteries, veins or any nerves that are present very in vicinity to them. And more than one incisional biopsy if required has to be taken in cases like where we have multiple lesions are present. Then take biopsies, incisional biopsies from one or more regions whichever have those characteristics of the lesion. And hemostasis, control of bleeding is very important in case of these biopsies. Most commonly with adequate pressure after the biopsy has been taken and the specimen has been removed is enough. Otherwise, we will go ahead with a suturing technique. Most of the time the bleeding controls there. If at all the bleeding is still not controlled, go ahead with a local hemostatic procedures like or local styptics like oxycell or surgicel can be given. And if the bleeding is from the bone, then go place bone wax to control bleeding from the bone. And if you think that the bleeding is from the gingiva and is not able to control it, then go ahead with your aminocaproic acid, and also you can go ahead with tamsulet etc. to get that hemostasis in that particular condition. And handling of tissue is very important. The technique of biopsy is important, so is the handling of tissue is important. Again, crushed specimens cannot be diagnostic. So when we are handling the tissue itself, handle it with the strength that is enough to hold the tissue. Do not crush the tissue with the forceps. Okay, crushed specimens may not be diagnostic, remember. And after removal of the tissue, do not place it in the external environment, because this can desiccate, this can make the specimen dried up, and the proper histopathological diagnosis cannot be obtained. So as soon as we take a tissue, irrigate it nicely with the amount of saline, copious saline irrigation, and then immediately put it in a 10% formalin solution. And this 10% formalin solution should be at least 10 times more than the amount of specimen that we have taken. So adequate formalin solution has to be present to place this tissue in a small bottle. This bottle can be again labeled with the name of the biopsy person, and also the biopsy number. The specimen number has to be written on the bottle, so that this will not get mixed up with other specimens present. And then when we're going ahead with an intraosseous biopsy is nothing but bone biopsy or hard tissue biopsy. The technique is usually, it is similar to the soft tissue biopsy. However, this hard tissue biopsy follows a different technique again. We will not actually do an incisional excision biopsy, but usually we go ahead with a core needle biopsy in case of this intraosseous biopsy techniques. And intraosseous biopsy biopsies are usually indicated if we find any radiolucent lesions within the bone structures, like before or radiopaque lesions also, like cyst or any tumors or any fibroosseous lesions that are present within the bone. In those cases, normally this intraosseous biopsy techniques are required. And this usually, when we see a radiolucent lesion within the bone, always do an aspiration, as I have already told you, before any surgical exploration, because to exclude various hemangiomas or any intraosseous hemangiomas or intraosseous arteriovenous malformations etc. To exclude that, go ahead with the aspiration biopsy. And then aspirational biopsy usually can be taken with the help of, as I told you, Jamshidi needle for mixed lytic or blastic lesions. Wim Trucut needle is most commonly used. For purely lytic and soft tissue component is present, then we go ahead with this Wim Trucut needles. Usually the size of the lesion could be, the size of the needle can be 7 gauge to 12 gauge area, we can take ahead. Then this is a picture which is showing about biopsy aspiration, fine needle aspiration biopsy from the breast lump. And this picture shows us bone marrow biopsy needles. Now coming to various artifacts, especially in the oral biopsy procedures, we have various, we encounter various artifacts when we take a biopsy and read it under, microscope while doing the process of histopathological investigation. In this, one thing is improper surgical removal. Improper surgical removal indicates that the lesion is, taken from a shallow and a broad area is being incised. We do not have a nice narrow or in-depth lesion is not present, in-depth specimen is not present in these cases. So to avoid this improper surgical removal, go ahead with a deep narrow incisions instead of going ahead with shallow wide incisions. And squeeze and heat artifacts, usually because of improper handling of the tissues, by using incorrect usage of the forceps, we actually squeeze that area. Heat artifacts are also usually seen, especially in case of electrocautery surgeries. And then improper fixation. Improper fixation is again if the amount of that neutral formalin solution is not present, copious amount is not present, adequate amount is not present, then that can lead to improper fixation. Curling artifacts can also be seen, especially if the lesion is if the biopsy specimen is very small. What happens? It shrinks, leading to curling artifacts. Hence, it is always important to take adequate amount of tissue. Not very big, but adequate amount of tissue for proper histopathological diagnosis is required to avoid this curling artifacts. And then foreign body artifacts also can be seen sometimes, especially this your cotton, your gauze pieces and suture material could be present within it. So That's the reason I told you, after you remove the biopsy specimen, irrigate it with saline so that all this, foreign body things like, the cotton threads there, the gauze pieces would be, washed off, and then we can directly fix it in the formalin solution. And then injection artifacts, that's the reason in injection artifacts, do not inject your anesthetic agent within the lesion. Go ahead injecting either by giving a block or injecting the solution at least 1 centimeter apart from the lesion or the site that has to be biopsy. And we have various interpretation of biopsy reports is again another important step in the case of biopsy taking. It is actually an important medical or legal document. Medical document for a final diagnosis, and legal document because we are actually maintaining the whole the case record. The case record itself is a legal document, hence it is an important part of the medical or legal document. And the parts of this report could be the patient information, definitely the demographic details where the patient's name, age, occupation, and their OP number, and also the biopsy number is very important here, and the location of the lesion from where we have taken the biopsy is again important. Clinical notes also is important, because in this clinical notes what happens is we actually give certain clinical features that we actually already have noted down. Those clinical features will also be included in the part of the report. And then gross description. Gross description is nothing but the pathologist's microscopic evaluation, the color of the lesion, the size of the lesion that has been, the size of the biopsy specimen that has been given, the color of that biopsy specimen. They nicely do they put two scales like this and nicely measure the amount of the tissue that has been given. There's 2 by 2 centimeter of tissue is given, such that we actually write the microscopic evaluation, color, if that lesion has any papillary structures that are present on the surface of the lesion. All this comes under the macroscopic evaluation under the gross description, and description of the specimen as I have already discussed, and any special processing techniques if they are using, like a punch biopsy has been done or a wedge biopsy has been done, or if they are using any other special processing techniques in form of fixation and etc., then we actually do that everything. We actually note down or record everything in case of your gross description. Then coming to your microscopic description, plays a very important role. In the microscopic description of the biopsy specimen, we actually write what kind of cells are seen, how is the basement membrane, how is the epithelial basal layer of the epithelium, is there any invasion into the underlying connective tissue, are there any neoangiogenesis present, that is small blood vessels are present within the lesion, are there any macrophages or lymphocytic infiltration. So based on all this, the cellular event that has been happening or that has been happened within the tissue specimen is written in your microscopic description. Finally, the diagnosis will come, where it will be a final diagnosis, will be based upon your all the features that are be listed above, and we come to a final diagnosis. Sometimes this final diagnosis could be again needs a clinical correlation. So in those cases what they write a clause in suggestive of clinical correlation. So we actually go back with this final report, check again is it clinically correlating with the lesion or not, and then the proper treatment plan is again sketched after going ahead with this in biopsy or histopathological report. The next is cytology. Cytology, as we already know, is study of cells. In this study of cells, Rudolf Virchow is the first person who actually said about cells, and this cytology from then has been came into existence. Normally this cytology, we have various types of cytology. Cyto is cell, logy is study. So cytology is nothing but studying of these cells, okay, and these cells are actually cytology techniques. We have various types of techniques, and we have exfoliative cytology, abrasive cytology, FNAC, imprint cytology, examination of body secretions, etc. Exfoliative cytology is nothing but where we actually scrape the mucosal cells or the skin surface, and the cells that are shed off are being studied. So the exfoliated cells are usually studied in case of this exfoliative cytology. And abrasive cytology is a technique where we actually go ahead in the earlier stages, earlier years. What happened is they used to use panicose gastric balloons. These panicose gastric balloons are nothing but the normally balloons with the outer surface is having this abrasive surface, and these balloons are endoscopically sent into the gastric lumen, and there they are inflated. Once they are inflated, they grow, they actually expand, and the abrasive surfaces which are present on these balloons scrape the the lumen, the surface of the gastric system. Okay, afterwards they are again deflated, and slowly through endoscopically the balloon is pulled out. Now the cells that have been attached to those to the abrasive area are scraped off and they are studied. So this is nothing but abrasive cytology. In due course of time, we have various balloons like esophageal balloon for case of occult carcinomas of esophagus. This is again recently used in case of technique in case of abrasive cytology. And then we have FNAC again, as I told you, in case of solid tumors, when we actually do an aspiration, we actually get few cells, and these cells are again kept on the slide, and then they are read for proper histopathological evaluation again. And then imprint cytology is nothing but the tissue specimen is actually pressed, cut into half, and it is pressed on a glass slide, and this glass slide is studied for those exfoliated cells. And examination of various body secretions is also done in case of this cytology. That is, sputum test is done, where again the sputum is drop of sputum is kept there, and then slide is fixed, and then we study those cells that are present in the sputum. Even peripheral blood smear, the body secretions of blood, is also studied in this technique, in various techniques of cytology. And breast biopsy, oral CDX breast biopsy is one recently used technique of exfoliative cytology, where this breast do a transepithelial biopsy, where this brush is actually have small bristles over it which are sharp enough to cause transepithelial scraping can be done. We actually press it across the mucosal structure and do a mild scraping until a pinpoint bleeding is induced, and the cells are then placed on the slide to study. Okay, so this brush biopsy usually gives us not just the scraped off cells, but the transepithelial cellular structures can also be studied in this case of brush biopsy. Indications of oral exfoliative cytology: when we are actually having oral premalignant lesions, in case of periodic review of oral cancer patients, oral exfoliative cytology does a wonderful job. In case of population screening of oral lesions and determination of suitable biopsy site, also this oral brush biopsies or oral cytology scraping cytology techniques are useful again. And when biopsy is contraindicated on medical grounds, for example bleeding complications are present, and if patient is under immune compromised state, in those cases where biopsy is contraindicated, we can go ahead with this cytology. In patients who are very much apprehensive or who refuse to go ahead for biopsy, for a screening procedure we can go ahead with cytology, and to assess any potential oral candidiosis or viral infections, we can go ahead with this cytologic procedures. Advantages is you don't have much amount of invasive procedure, it is easy to perform, it does not require much amount of specialized instruments, staining can be done very immediately, and the report can also be generated within few hours of time. It allows identifying cells of different types of epithelium, so it has good advantages, and it can be used to note the progression of the treatment and also for regression of the treatment. Early diagnosis of cancer can be done, and fast and wound healing in these cases, because we are not performing a biopsy, we are not creating a surgical defect there, we are just scraping off the cells, we are reading exfoliated cells there in case of cytology. However, it has its own limitations, where it has nowhere equal to biopsy. It is always an adjuvant to biopsy. Biopsy is the final diagnosis. This cytology will, because we are doing only a transepithelial study, we are not going into deep, we are not going into the connective tissue level in case of your cytology, so it is usually an adjuvant to biopsy. Here we read only epithelial changes. So much of false positive and false negative reports are seen here, and it cannot be performed in obviously keratotic lesions. So it is contraindicated in obviously keratotic lesions. Rapid fixation has to be done because there is a chance of desiccation in these conditions, and definitive diagnosis is not possible with cytology. We actually, once we found any defect within the cytology, then we go ahead with your biopsy specimen, and inflammatory lesions may be misdiagnosed as malignancy when we are doing a exfoliative cytology. So coming to conclusion, this biopsy and cytology are an important procedure in diagnosis, which actually allows the clinician to understand what the exact disease condition it is in a systematic order. Hence it is usually considered to be the final diagnosis of the defense, and this final diagnosis of the disease, which is based upon the histopathology will actually help us in planning a treatment also, and also in expecting the prognosis of the condition also in case of this biopsy and cytology. So this is all about your biopsy and cytology. We have seen various techniques, indications, contraindications, and also the procedure. Thank you.